Good afternoon. Thank you very much for having me. Again, I want to express my congratulations to Dr. Carr and Dr. Jameen for really a fantastic conference, and thank you very much for having me. The following are my disclosures. So the presence of multivessel coronary artery disease is truly a sine qua non for patients that are coming to the hospital with acute myocardial infarction complicated by cardiogenic shock. They'll come in critically ill, they'll have a thrombotically occluded vessel, severe LV dysfunction, hypotensive, and they'll often have at least one other vessel, if not more, that has a high degree of stenosis. In some registries, 50%, and in others, more than 70%. And this dates back to more than 20 years ago from the initial shock registry, in which they showed that at least two vessels outside of the infarct-related artery would have more than 50% stenosis. Not surprisingly, those with single vessel disease did better than those that had left main or three vessel disease. And the data has been borne out over the last decade and a half in a number of registries, both in the United States as well as around the world, that in addition to other historically validated markers of increased risk, whether it's advanced age, delayed presentation, unsuccessful reperfusion, the need to be on the mechanical ventilator, dialysis, or the need for mechanical circulatory support, that having three vessel disease is associated with worsened survival. Now, over the last decade, we've learned that in more garden variety acute coronary syndrome, that complete coronary revascularization, whether it's at the index presentation or as the complete trial showed us, up to 45 days later, is associated with better outcomes. And this has been shown in a number of studies, whether it was dynamic 3 per multi, PRAMI, and most recently with complete and with culprit. And as you can see here, that the numbers that needed to treat for reductions in cardiovascular mortality, MI, and revascularizations are pretty low. And as a result of that, there has been a shift in paradigm that emphasizes complete revascularization in these patients, whether it's in the ACC guidelines or in the European Society of Cardiology. But as we know, not all AMI is the same. I mean, we can't compare apples to oranges. Patients that come into the hospital with more garden variety MIs, they'll get a transradial access PCI, and they may go home 48 hours and sometimes as low as 24 hours. Whereas those that are coming to the hospital in shock, they have severely deranged pressure-volume loop relationships. They are in severe systolic and diastolic dysfunction, elevated filling pressures, severe peripheral vasoconstriction, a SIRS cascade, refractory lactic acidosis, arrhythmias, and they can die. Now, initially, the data that came out that was opposed to doing complete revascularization in garden variety ACS was data that came from the NCDR and from the New York State Registry that said, well, because those in shock do worse. But now in AMI shock, there's been data coming out. This is from the Milotte and colleagues. It was a multi-center French registry that showed that multivessel PCI can reduce MI can reduce death in these patients both at 6 months, and it can also reduce cardiac arrest and shock death. This paper that was a Korean registry came out and it showed the same findings, both with regard to reduced death as well as composite of patient-oriented outcomes, and whether that was death, MI, or subsequent revascularization. And the effect of multivessel PCI was consistent across all the various subgroups. And as a result of neutral to slightly positive data favoring multivessel PCI, the 2017 guidelines, whether it was in the US or whether it was in Europe, favored undertaking multivessel PCI and cardiogenic shock if it was deemed suitable and appropriate to help the patient with their outcomes. And then comes this very seminal paper, the culprit shock trial, first with the 30-day outcomes 2017, and then the landmark one-year data in 2018, in which they looked at patients coming to the hospital with either STEMI or non-STEMI cardiogenic shock with at least two vessels with greater than 70% stenosis, and they were randomized to either culprit vessel PCI with the option of stage revasc or immediate multivessel PCI, and they looked at death or renal failure leading to renal replacement therapy, and what they showed was that that was significantly less in the culprit arm. In addition, there was reductions in death from any cause, and there was also reductions in death, recurrent MI, as well as repeat revascularization, as well as hospitalization for congestive heart failure. Now, they also showed that amongst the pre-specified subgroups that the results were consistent. And at the one-year data, again, they showed that while they, after 30 days, the lines started to come closer together, but at 1 year, still they showed reductions in death or renal failure, But the other markers that they showed were not as significant, but they did show that at least in the culprit arm, at 1 year, there was an increased risk of rehospitalization for heart failure, as well as an increased risk for repeat revascularization. So in the most recent data that's come out, again, post-2017, so 2018 and thereafter, first, what was published by Dr. Rabb and colleagues by the Interventional Cardiology Council, they recommended PCI to the culprit vessel only, and in the European guidelines, multi-vessel PCI was given a class 3. So what are some of the takeaway points? Well, it's the first randomized controlled trial comparing multi-vessel PCI to culprit vessel. Is it truly contemporary? That's up for discussion. These were patients that underwent primarily transfemoral access, and we know from data by Dr. Malmus and colleagues in England, as well as by Dr. Pancholi, that perhaps there's a benefit with transradial PCI. Only a quarter of these patients underwent MCS, and the majority of them got balloon pumps, so the whole concept of door to unload versus door to balloon. A quarter of these patients had chronic total occlusions, and we know from the Explore CTO trial, which excluded shock, at least there's no additive benefit with regards to undertaking a CTO either at the time or shortly after a PCI with regards to LV geometry and remodeling. But it also said, don't underestimate the role of complete revascularization. There were a number of those in the culprit arm that underwent immediate multivessel or staged. And we also know from data from around the country that shock teams and protocols can improve outcomes. And perhaps that may have been a factor that was not included in the care of these patients. So in conclusion, what can we say about complete revascularization and AMI shock in the year 2020? Well, what we know from the culprit shock is fix the culprit vessel first with staged revascularization of the non-infarct-related artery once they're stabilized. Have a low threshold for ad hoc multi-vessel PCI if they have refractory shock. Leave the CTO alone for another day. But what we don't know is what about what we're learning now from the National Shock Initiative and other data that's been coming out? Perhaps upstream LV unloading in these patients, would that mitigate the adverse effects of contrast and LV dysfunction and acute kidney injury? Would having shock teams and protocols have changed the outcomes? And what about vascular access? There was a high rates of bleeding complications. And as we're learning at this conference, that vascular access complications and bleeding outcomes are just as important as refractory cardiogenic shock in the death of these patients. So complete revascularization is important, but there's still more to be learned. Thank you.
Comments from the panel?
Forgive me, I'm not, it's been a while since I read the culprit trial. Were any of those patients, these recommendations were based on patients that were not on mechanical support, correct?
Only a quarter of them received mechanical support.
That was subsequent or at the time of the original ACS event?
We don't know.
Okay. Then I would just turn around and ask the audience or the panel, our practice is to go after the culprit lesion and leave it alone and then usually come back a week later. Don't touch the CTOs at all. Nobody died from a CTO last night, acutely. But if they're on mechanical support, right out of the gate, we tend to favor a multi-vessel approach to revascularize as much of the heart as possible. What are other people doing?
Well, at our institution, we do the same as well. So whether we upfront put them on support or whether it's done in the middle of the case or at the conclusion, we will do the culprit vessel. One of the questions has been what is the role of FFR or other physiologic interrogations in these patients? And we don't know that. These are people that are coming in very inflamed. They have systemic multi-vessel clamping down and stenoses. So I don't know what the answer to that is. Clearly Flower, which is one of the studies that, but again, in non-shock patients, but in a more garden variety will give us more data about that. But in our practice, it has been fix the culprit vessels, support them, let them recover, let them get out of this metabolic phase of derangement, and then either prior to discharge or very shortly thereafter, revascularize what needs to be done.
So our approach is, I think, more similar to yours. Individuals that are hemodynamically compromised, we would revascularize not only the culprit. The problem is it's often difficult to know the culprit. You may have EKG or other things. And if there is another lesion that we feel is hemodynamically significant off of either visual estimation or other things, we would do that. There may be other lesions that are intermediate or uncertain. Those we would not revascularize at that setting. We might bring those back at the end of that hospitalization to make sure that we have, in fact, not left hemodynamically significant lesions.
I think one of the issues is in the looking across the country, not every cath lab has full mechanical support capabilities, and some have more comfort than others with some of these devices. And so they also have more comfort than others in terms of complete revascularization, because sometimes some of these lesions are really problematic. And, you know, an experienced interventionalist will look at it and go, I can delay on this one, or I can probably fix this second lesion, but you know, do I put them on support? Do I not? Do then I ship them out to our, you know, hub and spoke? If you're the hub getting a patient who's in shock with multi-vessel intervention, catheters coming out everywhere and bleeding on, you know, 2B3As plus the DAPTs plus whatever else the patient's on. I think it is truly, as interventionalists, I think we have to think of the continuum of care of this patient, where we're sending them or how we're taking care of them to prepare them to go to their next step. And I do believe, as you guys do, in terms of as complete revascularization as possible, especially if you put them on support, because you start using up all their access sometimes, and the bleeding problems and bringing them back are always an issue.
Jim, could I ask you and Behnam, anyone else to comment? You know, just like Ms. Wajid said earlier, I mean, they did this randomized trial so that there can be some guidance, at least in cardiogenic shock. Do you think we learned something about the biology of an infarct? And we're getting back to the issue of what, you know, Naveen is trying to prove or disprove, that maybe you don't, I mean, you know, we think more revascularization better. I mean, right now, as we speak, I believe it's the NYU team is trying to come up with a randomized trial for CABG in cardiogenic shock, complete revascularization, and on the heels of the culprit study. So my question for you is, I mean, I'm not an interventionalist, but if this were my patient, at Hopkins, as a fellow, we used to PCI everything in shock, and we would be, you know, on our third, you know, defibrillation on balloon pump support and you know, sweating it. But is this, to Jim's point, is it just the issue of complications, or do you think there's something about the biology of myocardial infarction that you should just get in, get out for now, and then wait the unload results?
I can only comment, you know, we talk about three-vessel disease or two-vessel disease. We talk about CTOs. We don't really talk about the big arteries or the little arteries or the stump occlusions or the long, severely diseased patient, the 70-year-old with calcified vessels versus the 40-year-old who has three-vessel lesions that are all soft and you can pop them all with stents in 15, 20 minutes. It's the amount of contrast you're going to use. I can go on, but the picture is, the angiogram is really what sets us up for, I can speak for my colleagues, what sets us up for whether we're going to move ahead aggressively or not, and then how much support.
Yeah. I mean, even in the culprit, while they did include CTOs, the success rate was about 33%, and they didn't undertake retrograde using reverse carts and septal feeders, and they actually had a contrast limit of 300 cc's. So if there is another lesion and you have to do complex interventions with atherectomy and all those things, that's going to increase ischemic time, increase your filling pressures, your PA pressures, make your muscle even more ischemic and stiff. Perhaps it's better to wait until they're stabilized and before they've been discharged.
So this is a fantastic discussion. You know, I'd be interested in hearing other experience from some of the surgeons in the panel in the audience about their experience taking these patients urgently for bypass. I know that at my institution, the surgeons are rarely, if ever, interested in that, to the point where I almost wonder why I call them. If the person's in shock, you know, it's going to be PCI or nothing. But that, my understanding is that's not the data from the shock trial. So I'd be interested in hearing a surgeon's perspective.
I mean, our experience with our institution is usually if it's, I've done actually a couple of weeks ago, but that was a complication that happened in the, while they couldn't open up and they perforated the lady and I had to take it. Otherwise, I know a surgeon is doctor, not me, so this PCI is, to me, is just much more preferable for these people. even, you know, restore the, they're in the shock, and it's not just the heart, it's the entire SIS and stuff, and they struggle to, it takes a long time to rehabilitate these people, a long ICU stay versus just the PCI, and then a couple days recovering the, which has been our experience with our cardiologists.
We do a lot of surgical impella implantations, axillary 5.5s, direct LDs, and in that context, if you're going to the OR and you're supporting the patient, it's not uncommon to do surgical revascularization at the same sitting. But again, your surgical indication was first support, and you're adding on the revascularization.
The other tricky part is where the patient's coming from. If the patient's coming from 3 hours away, you got a call that they have an LAD occlusion and the patient's in shock. By the time I could actually revascularize the patient would be at least 5 hours from the time they hit their door. So by that time, myocardium is already dead. So should we put an Impella 5.0 at that time and prepare for the next steps of his journey for heart failure is a conversation that I have up front. And plus, the way STS, Society of Thoracic Surgeons, are, now they are termed as salvage cabbage because the mortality is so enormous about these guys. So we say yes if the clinical circumstances is yes, but if it looks like he's destined for a heart failure patient, then it's a separate discussion.
Are there any other questions from the audience or the panel? No. Well, thank you very much. Excellent.